let's take you back to this one, which was the previous case that actually Roland was doing. And the patient had a classical end spiral, which is a relatively flat end spiral. And what I would like you to do on here is look at this image, this is the anterior posterior. And then on the lateral view, you can see this acute angulation at the junction between the sigmoid and the descending junction. And the solution to this problem is here. You need clockwise torque. You need to steer the tip with very fine tip movements to avoid hitting the wall. So as you pull the scope back, the tip will advance. To help the tip advance, we sometimes aspirate. In this case, it was underwater, so that was less likely to be helpful. And then the key thing here is slow and gentle insertion. And then only a few moments later, we had progressed to this. And if you look at the image here, this looks not dissimilar. If anything, the angulation has become a bit more acute on the AP view. If you look at the lateral view, it's flipped. So if I trace this out in this direction, it goes up and over. And if I trace in this one, you come over the top and back round again. And in fact, to move from this to this, what has happened is you've applied anti-clockwise torque, which is actually the opposite that was required. And if you recall, what Roland then suggested was to move the patient from the left lateral into the supine position. And just to go through that again, this is your body. Not sure how I'm going to draw the body like that, maybe, I don't know. Feet sticking up here.
End view from the feet.
End view from the feet, yeah. So the feet are sticking out here, and the patient's in the left lateral position, and then they move into the supine position. The feet are here. The patient has rotated anti-clockwise by 90 degrees. Now, if you hold on to the scope, which is here, and don't allow it to rotate, as the patient rotates anti-clockwise 90 degrees on the scope, in effect, what you've done with the scope is apply 90 degrees of clockwise torque. And if we go back to this, it's clockwise torque that was required to resolve this particular issue. So moving the patient will have helped resolve some of the problem. And at that point in time, I think when you're moving the patient, I think if you've got paying close attention to the screen and you've got stability of the scope as the patient is moving and the patient is rolling, if you can have minor adjustments of the tip control, often the scope will straighten itself with just the action of rotating the patient. And there was an element of that in your case. Is that fair to say?
Yeah.
So that's the first thing.
Tip control was the problem.
Tip control was the problem. Now, to come to a different problem, selecting your choice of colonoscope. So just let's look at the different instruments, the relative sizes, and the characteristics of those instruments and how they may benefit you in different situations. So firstly, if we look at an adult colonoscope, it will have a diameter of sort of 14 or 15 millimeters. The pediatric scope tends to be a little bit thinner, and the ultra-stim slope is usually of the same sort of diameter as a gastroscope, so 11 to 12 millimeters. So there's a significant difference in the diameters of the scope. If you think about the stiffness of the instrument, clearly the fatter scope is going to be stiffer than the thinner scope. And what that does is it increases the lateral force. So if you're going around a particular bend, there's going to be much more force with the CF scope than there is with the ultra slim, which is why when the colon's particularly rigid or sensitive, sometimes it's easier to go around with a slimmer scope. The other issue you want to think about is how much tip angulation you're needing. So in a bigger scope, the tip angulation is slightly less than in a PCF, and then you get the maximal tip deflection with a gastroscope or an ultrasim scope. So you've got either the stiffness of the scope or the amount of deflection that you're going to achieve using that scope. And the other thing to think about, and I've got it up here, is your near focus. So some of the instruments have got this near focus or zoom facility built into them. In our department, the CF has got it, the PCF hasn't got it. So that one's got it, that one hasn't got it. The ultra slim hasn't got it, but the OGD scope does have it. Anyway, so let's look at the potential issues here. So for a long loopy colon, obviously the thinner the scope, the more likely you are to form loops. So you need, for a long loopy colon, you need a stiff scope. So normally we would use an adult scope for a long loopy colon. For a fixed colon, the problem is the angulations are usually very acute. And here you're going to be using a lot of tip steer. It's also usually a bit uncomfortable for the patient. So there we move towards a PCF and probably an ultra slim slope. And the other thing that we haven't discussed is imager compatibility, which you've seen has been very useful today. So if you look at the imager, it's a tick here, it's a tick here, and it's a tick here, but it's not here. So the issue with the long floppy scope is this is probably a better scope, but what you might lose is the ability to have the imager. And once you're beyond the difficult bit, obviously the ultra slim scope tends to lead to looping. And actually, although you may get past the first part of the sigmoid colon, you have to consider what follows that. The sigmoid colon effectively functions as a stiffener once you've got through it, but actually if you use a super thin scope, you might have significant difficulties in looping, and without having some form of scope tracking device, that may be a little bit difficult to sort out. So we would think about oscillating between these two and probably start with this and only move to the ultra slim scope if there's a real problem. Now, every patient is different and it's difficult to generalize, but in obese patients, for some reason, your natural scope configuration changes. And what is supposed to be a retroperitoneal section, or certainly maybe the more proximal part of the sigmoid colon, will tend to bow out, and you get what we call this lateral bowing. So as you move through this sigmoid colon and you approach the splenic flexure, the colon moves out an awful long way in this direction. And this can be difficult to control. It can make the splenic flexure rotate posteriorly, and it can make the angulation at the tip here quite acute, and it can make it very difficult to progress. So to solve this problem for obese patients, you need a stiffener, and ideally you need a stiffer scope. And as a word of warning, you also need a large trolley, or whatever you call them. So the stiffest scope is going to be the CF scope. So if we have a very big patient, so if someone comes in on what we call a striker bed for us, which is usually the morbidly obese patients, I will immediately ask for a CF scope on the basis that you're going to get a lot of lateral bowing in the left colon, and usually there's a lot of transverse dipping. And if you're trying to control loops, it's a stiffer scope that works. So for your obese patients, I tend to use a CF scope. What about the thin people or the people with a hypersensitive colon? Well, the problem here is to do with pain receptors. And pain receptors respond two ways. One is to stretch, and the second is the rate of stretch. So if you have a bend, you're going to stretch in this place here and you're going to get pain. If you push in slowly, you'll get pain. If you push in really quickly, you'll get an awful lot more pain. So the key things here are we're going to go very slow. We want really to reduce the lateral force if we can. So we want to use a thinner scope. Ideally, you want an imager because you want to resolve the loops as soon as possible if they are forming, because the patient just will simply not tolerate that. And usually need to have the option of having some sedation. So we do a lot of patients unsedated, and normally if we have a very anxious, so the other thing that increases the pain receptors actually is anxiety. And the other thing is hypoxia. So we try to allay the anxiety of the patient by reassurance. that works to some degree. We can reduce any hypoxia by giving them oxygen, try and minimize the sedation. But the flip side to that is the sedation also helps to reduce their anxiety. So there is a balancing act there. But in terms of scope selection, we would use the thinner scope. We would move very slowly, and we want an imager. So for this one, the thin hypersensitive patient, we will use a PCF scope.